Disclaimer: views and opinions expressed in this video, including off-label discussions, do not represent those of MurmurMD, medical device companies, or any healthcare organization, and are solely those of the speakers involved.
Thank you everyone for watching this video. This is Elliot Groves. I'm the left atrial appendage closure moderator for MurmurMD and part of the Palo Alto Medical Foundation. We have the great pleasure of having Frank Corrigan from Wellstar in Georgia here with us, who's both a little bit of a renaissance man, an interventional cardiologist, and an expert in CT imaging, particularly for left atrial appendage closure. So Frank's got some great cases for us. Please take it away.
All right. Well, thank you for having me. CT is something that's really started to take off for left atrial appendage closure. When I started, we were doing TEs before, TE during the procedure, and then TE afterwards. And in these kind of frail people, that turned out to be kind of a ridiculous thing to do. So CT both before and afterwards, I think, is very beneficial for these kind of high-risk patients, patients that bleed and, also have AFib or, have a lot of comorbidities. So anyway, what we wanted to talk about today was looking at CT after left atrial appendage closure and some of the nuances that are associated with that. I know that a lot of people who get CTs afterwards, sometimes the readers, sometimes the implanters aren't familiar with what type of things we see, and it can be really confusing. Elliot, ask me questions. I've got a couple cases I wanted to show, which I think kind of illustrate some points. But what's been your experience with left atrial appendage closure CT afterwards thus far?
Yeah, it's a great question. So I am span the, I guess, more ridiculous side of this. We don't do pre-imaging, but we do post TEEs, and I totally agree with you. Our complication rate from the actual procedure is damn near zero. Our complication rate from the TEEs is not zero. So we've had bleeds, lacerations in throats, all kinds of stuff. So we've been steadily kind of working our way more towards CTs. But I'm excited to hear what you have to say, because I think one of my issues with it is the radiologists are radiologists, and I think I'm a little bit limited perhaps in my own ability to interpret these studies afterwards and to know exactly what it is that I'm seeing. And so I'm looking forward to hearing what.
Yeah, a radiologist reports out what they see, and it's a little bit nuanced. Boston Scientific, when they initially designed the studies, having a 5 millimeter leak is actually quite liberal. So, what we see on CT is obviously a whole lot more sensitive. While we're talking about that, I'm going to pull up a case. So this is a patient who had a CT after their Watchman. When I review them, we don't always have all the cardiac phases, but usually we'll have systole and diastole. So I like to pull up one in systole or one in diastole, just because there might be motion in one phase, and motion can kind of make it confusing. So we're pulling this one up. And so here are the axial, sagittal, and coronal planes. But basically what I do is I want to line up my planes on the Watchman device, like we would when we measure for compression at the end of the case. So I'm going to move my planes over to the device. We'll zoom up on it a little bit. And you can see there is a little bit of motion. So I'm going to try, this is systole. I'm going to try diastole, and diastole looks a whole lot better. So we'll use this one for the purpose of analysis. And so what you can see before I've manipulated the planes, you can see there's this dark area next to the device on the atrial side of the device. And obviously the question is, okay, is that device-related thrombus? That's primarily why we're doing this, and also to assess for leaks. And it can be really confusing. What happens a lot of times is the way the limbus or part of the atrium folds over the device, it's just part of the atrial wall. So the way I do this to figure out what I'm actually seeing, what's there, so we line up the planes on the device just like we would when we're measuring compression at the end of the case. And so in doing that, we'll have the Watchman device and 2 planes, and then you've got kind of a cross-sectional area of the device. Some people measure compressions on CT. I don't really know if that's relevant because you're not in the procedure, but this would be how you do that. But what I'm going to do is using the plane that's in cross section, we'll just scroll around the device and try to understand its positioning a little better. So in doing this, we see 2 things. If you look in the top left, you see the limbus, and you see all this stuff kind of around the threaded insert on the device. So what is that? When I scroll in and out, you can see that it's not like jagged. I'll show you an example of a thrombus later. It's not jagged. It's all fixed primarily right around where the threaded insert is. And it's very kind of flat in a sense. And so what this is the limbus is hanging over the device. And then also there's, you may have seen this in a case, after a device is implanted, when there's a lot of compression or sometimes when there's a leak, the fabric on the device kind of oscillates. Have you seen that during a case?
Yeah, definitely. And I mean, and that you concern sometimes with, I mean, for me, with over compression and kind of pleating of the fabric a little bit. But yeah, definitely the oscillation is particularly in someone's in sinus and they have a pretty vigorous atrial kick. And
so what we've determined this to be, this, if you look in the top right, this is all thrombus underneath the fabric. If there were device-related thrombus, you would see something jagged coming off of this into the left atrium. So this case this is a tissue border over here on the device, and then a little bit of thrombus under the device. Under the fabric. And then to assess for leaks, essentially from our cross-sectional view, we'll just kind of scroll around and try to see where it's opposed all the way around. And this device is a very good closure. It's opposed all the way around, and you can see there's no contrast getting past the device. So the appendage is closed, the appendage is thrombosed, and this is a good closure. So I bring this example up because it was read as potential device-related thrombus, but this is not, because there's not anything coming out jagged looking into the atrium. So keep that in mind, and I'll show you one that is thrombus.
That spot there where the device is kind of opposed to the limbus, that's been a spot that I've had a lot of ambiguity. Is that generally tends to be the case?
Yeah, I mean, so does a gutter fill up with thrombus? I mean, yeah. You know, I just, the way this is positioned, if there was a thrombus, you would see something coming out this way. So looking, and this too here, I think is not thrombus. That's outside of the device in the atrium. I think this is the way the fabric is kind of puckered up.
Yeah, it makes perfect sense.
So this is kind of a common thing that comes up that we see. Now, another thing that can happen, you can see right along the threaded insert, it's real dark right there. That is a beam hardening artifact that happens when you have metal in the body. If you've ever done a TAVR workup and someone has a hip replacement, you run into that on the CT. Sometimes every Watchman will have this kind of dark part right around it, just because there's a lot of metal right there. Sometimes people confuse that for thrombus also, but that dark area right there is a beam hardening artifact that you would see from any piece of metal in the body, pacemaker, hip replacement, etc. So this is a good closure, and it's kind of got some ambiguities. Let me show you another case here. So again, I'm going to pick 2 phases, one's in systole, one's in diastole. In your system, you may not do that, but I find it helpful just because there can be some motion.
Yeah, that's a great idea.
when we're planning TAVRs, actually pick a couple different phases and then try to see where the valve's the most open. Sometimes it's 20%, sometimes it's 30%. But that way you make sure you have the largest valve area.
Yeah, I do the same thing. I think that's a really good idea. Off topic, but
yeah, off topic.
Yeah, it's certainly a good idea to measure TAVRs in multiple plates, because I mean you want to see when the valve is the biggest, most open, and that's the size you want to put in.
So here's our second case. You can see there's a lot of motion in diastole here. So we'll go to systole, and it looks a lot better. Yeah. So I'm going to line up on the device, and so we'll follow it around. And so if you look in the top right, this kind of looks similar to what we were looking at before. Is this thrombus or is it not? And so what I can see over here is that there is something that kind of protrudes into the atrium. Now, how do I know that for sure? If in the cross section, I'm going to line up my crosshairs on the threaded insert. You can see how this protrudes out into the atrium. You can see it in the cross section. I should probably go back to the other case because it didn't behave like that. So this is example. This is kind of this is an example of a thrombus, but it's kind of a little bit more subtle than some of the thrombuses you may have seen. So this patient we put on anticoagulation, and I actually don't see a follow-up on her. So I apologize for that. But
and are you
see how this looks a little different than what we saw in the last case?
Yeah, definitely. I see your point about the non-linearity of it. It's more of a complex and non-uniform.
Yeah, and in the cross section, you can see how when I go into the atrium from the device, this area, this thrombus, which is right here, protrudes out, and so that means there's thrombus on the device.
And are you looking at this with the aortic package of 3-Mencio?
So 3-Mencio does have a left atrial appendage package. Yeah. I found that I can do most of what we need to do just in the 3D portion in the aortic, but so that's what I'm using here.
That's what I've used too, because we don't have we have the mitral on the.
I trialed the left atrial appendage package, but it didn't offer me all that much more. The TruePlan software from Boston, I think, is pretty neat stuff. But anyway, this is what we use right now. All right, let me show you another case.
Yeah, these are great pictures. That's a very strong. I mean, it is a very noticeable difference.
Yeah. So this patient has a good closure. You can see the device is, it's all thrombosed behind it. But nonetheless, they had some DRT.
Yeah, so how are you guys handling those? Again, a little off topic, but what do you do with DRTs?
So, good question. We're usually just putting them on either Eliquis's Xarelto for 6 to 8 weeks and then repeating imaging. Sometimes we'll do that and the thrombus will have shrunk, in which case, the decision kind of becomes kind of patient specific as to whether or not you want to change to something more aggressive or just continue to course. But usually we use one of the DOACs and repeat imaging in 6 to 8 weeks. We had a case that was really a very persistent thrombus, and we ended up putting the patient on warfarin and Plavix, and it went away. But that's certainly unusual to need those. It seems, but now that we're doing a whole lot more CT, I think you find a lot more stuff. I'm curious as to did we miss things previously on TE? I don't know.
Yeah, I think probably. I mean, my uneducated opinion. I think that the more CTs we've done, the more stuff we see. Sometimes I wonder if it's a little you see some stuff that maybe, you need your kind of level of expertise to discern. Because I think it's some, programs they would have called that first case thrombus, but your explanation it makes perfect sense. I think just trap behind.
You'll see that. I feel like we see that all the time. Someone calls it thrombus, and it's like this little kind of very smooth dome that forms on top of the device. And and if you go back to the TE during the case, almost always they'll have that oscillating fabric. And it's just the device is compressed or there's a leak, and it's, causing the thrombus to form under where it kind of puckers up.
So are you doing your first post-procedure imaging off anticoagulation?
So our protocol is every patient at least gets dapped after their implant. If a patient has chronic atrial fibrillation, or we see a lot of smoke during the case, So if the patient has chronic atrial fibrillation, or we see a lot of smoke in the case, in the appendage, we will consider doing anticoagulation until they get their study. So this is another patient post Watchman. So in order to take a look, we picked, this is the diastolic phase. I also picked up the systolic phase. So we'll go up to the device and we'll line up our crosshairs on the surface of the device, just like we would when we measured the compressions in the lab. A little bit of motion in diastole. Let's see if it looks better in systole. I think it looks better in systole. So we'll take a look here. And here, first off, you can see that there's the beam hardening artifact around the threaded insert. Sometimes people can confuse that. Kind of like we were talking in the previous case. But what we can see when we scroll around the device is there's this uncovered lobe right here. And so would you have seen this in the lab? I mean, hopefully, but this is a, this is a leak, and essentially it's an uncovered lobe. The patient has trabeculations back here. So I feel like, there is some residual risk of thrombus and stroke from something like this. Now on CT, how would we measure this to quantify it? Basically what we've done is when we see a gap more than 5 millimeters, that's when we get concerned and say patients can't come off their DAPT or their anticoagulation. But what you're supposed to do is measure it perpendicular to the plane of the device to the farthest away point on the atrial wall. So in this case, I'm going to zoom up here, and we call this a like 4.5 millimeter leak. So this would be concerning. Can you say that this is a successful closure? I'm going to show you some data that came out at New York Valves a couple weeks ago. But I would report this out as a 4.7 millimeter leak. Now, does that correlate to a 5 millimeter vena contracta on a TE? I think the TE definition that all the trials were based on is very specific, but this is a little more sensitive. So if you bear with me here, I just want to share this data real quick.
Yeah, that's interesting to kind of discern between leak versus uncovered lobe. I mean, I guess I would, in my own practice, I would just, I don't know that I would even call this a leak. I would just say there's a, clear section of appendage that's not covered.
So this is this paper that came out, was presented at New York Valves back in April. where this is the first time we actually have data after Watchman for patients who have undergone. This is the first time we have data after Watchman for CT. All previous to this, everything had been anecdotal. So in this study, they importantly, they list out kind of exactly what we did, how you measure and everything. And I could go through that again. But interestingly, they looked at 4 groups: patients that had complete opacification, patients that still had some contrast behind the device. Then there was mild PVL 0 to 3, moderate 3 to 5 millimeter, and severe greater than 5. So if we just go down to the event rates, having a severe peri-device leak was a problem, more than 5 millimeters. So importantly, having a moderate 3 to 5 millimeters is associated with slightly more events. So it's not negligible, but I think this kind of gives me evidence that this 5 millimeter gap measurement makes sense. And then if it's between 3 to 5, I think you just have to have a conversation with the patient because they do have a higher event rate, whether it's stroke, cardiovascular death, major adverse cardiovascular events. But the bulk of all the events in this particular study are in the patients that have 5 millimeter or greater gaps. So this was a very important study, I think, for this field because we were basically basing everything on conjecture until this was available.
Yeah, it's nice to see also that these small leaks aren't typically associated with a dramatic increase in events. We like to leave perfection, have no leaks, but realistically, there are a subset of patients who are going to have a 2 millimeter leak. But that's I was similarly encouraged by the non-increase in event rates in that group.
Yeah.
So you're doing these CTs. At what point do you have a different protocol for, say, someone who's in permanent AFib or, say, long-standing persistent AFib versus paroxysmal and is mostly in sinus, or do you have a kind of a standardized protocol for 6 weeks of anticoagulation or 6 months of DAPT, and then we image? What's your kind of general protocol?
Our protocol is if a patient is in sinus rhythm, if they have paroxysmal AFib, obviously, then they'll be on DAPT and get a CT at 45 days. If they're have chronic atrial fibrillation, or if we see a lot of smoke in the appendage or in the atrium, we'll put them on anticoagulation and then scan at 45 days on that anticoagulation.
So then what do you do with those cases where, say, you have a bilobe appendage and you've put the lobe part of the amulet into one lobe of the appendage, and then the kind of manhole cover or hat is over the ostium?
Okay, great question. Great question. So the hat, you would want to then close that other lobe.
Yeah.
So that's a unique circumstance. But if that hat isn't closing that other lobe, then you have an issue. But sometimes on the amulet, you'll see that the hat's kind of tilted and there's like smooth atrial wall with contrast on it outside the appendage. And that's okay. But if there's a lobe that has trabeculation in it that's more than 5 millimeters in diameter, you'd be concerned about that.
Right. Yeah. Well, thank you very much. I mean, these were really, I think you hit some of the things that I have questions about. And I'm sure many other people have questions about what you commonly see on CT. And it's nice, I think, for you to illustrate from a cardiologist and implanter's perspective how to analyze these things without, the radiologist alarmist approach of thrombus.
Yeah.
So that's great.
I joke that as cardiologists, we're the only specialty in medicine, not looking for cancer all the time. So when you're a radiologist, that you're trained just to find things and report them, but a lot of times there's some nuance.
Absolutely. Well, great. Well, we really appreciate this. That was really high yield, super educational for me, and I hope for everyone else. And we look forward to your continued great cases on the app. And like I said, really appreciate it.
All right. Well, hey, thank you. And thanks for having me.